When we speak of cardiac muscle, we are really discussing two different types of cardiocytes, specialized cells and contractile cells. You will have extensive lecture on these cell types, but for right now, a brief overview of the specialized cells is warranted. The structures shown in this picture are specialized cells. They are called specialized because they do not have stable resting membrane potentials. As such, they are able to reach threshold without a neuronal stimulus. The reason behind their fickle membrane potential will be covered during lecture. The specialized cells start with the sinoatrial node, which is known as the pacemaker of the heart because it is the fastest of all specialized cells to reach threshold. The sinoatrial node is connected to the atrioventricular node by the internodal bundles. The AV node leads to the atrioventricular bundle, or bundle of His, to the right and left bundle branches, and finally to the Purkinje fibers. You should know that these specialized fibers are all connected with each other via intercalated discs, as well as being connected to the contractile cells of the heart by the same intercalated discs. As such, when the SA node reaches threshold and spikes in action potential, this electrical event can spread quickly through the cytoplasm of all the heart cells because of their intercalated disc contacts. Subsequently, the atria will contract in syncytium, and the ventricles will also beat in syncytium. I want to reiterate that the heart does not require a neuronal stimulus to generate an action potential and cardiac cell contraction. But the heart is innervated, so the question becomes, what are these nerves doing? First, let's remember that the nerves innervating the heart are either sympathetic or parasympathetic fibers. These neurons, when they release neurotransmitter, will alter the rate and force of the heart contraction. Let me say it again. These nerves do not instigate the action potential, but they do modify how quickly the specialized cells reach threshold and therefore alter heart rate and inotropy, which means force of contraction. Remember that the sympathetic fibers would release norepinephrine to bind to beta-1 adrenergic metabotropic receptors to increase heart rate and force. And the parasympathetic fibers would release acetylcholine on muscarinic metabotropic acetylcholine receptors to decrease heart rate. The innervation of the heart from the autonomic nervous system is greatest at the sinoatrial node and secondarily at the atrioventricular node. Sympathetic fibers also innervate the ventricular walls, thus they modulate inotropy. Let's review the heart muscle, or the myocardium. The cells that create the myocardium are called cardiocytes. You'll notice in the top left picture that these cardiocytes branch, they are also striated and mononucleated. Additionally, you'll notice special junctions in between each cardiocyte called an intercalated disc. These are interdigitating folds that create mechanical junctions through desmosomes and electrical junctions through gap junctions. These intercalated discs are extremely important in allowing the heart muscle to beat in syncytium, that means in unison, and I will give considerable amounts of lecture time to describe the syncytium. Let's review what was just covered in the previous slides. Please remind yourself that the cardiac muscle fibers are branched and have intercalated discs. These have gap junctions and are a pathway of low resistance, so the electrical signal can spread from cell to cell. This allows the heart muscle cells to act as a, quote, functional syncytium. That means the heart cells can contract as one. Two types of fibers are going to be found in the heart, and you'll learn about them. They are called specialized, or leading cells, and contractile, or following cells. The specialized cells have an autorhythmic nature. That means the action potential is generated within these cells due to their specialized membranes, not from nerves or hormones. These cells have a special intrinsic rhythm. Nerves and hormones merely modify this intrinsic rhythm. In class, you now need to take your knowledge of the four chambers of the heart, the septa, and the valves, and apply it to the physiology of the heart. I need to speak a little bit about the non-conductive connective tissue skeleton, or fibrous skeleton of the heart. The fibrous heart skeleton is located between the atria and the ventricles and is formed from dense, irregular connective tissue. The fibrous heart skeleton performs the following functions. 1. It separates the atria and ventricles. 2. It anchors the heart valves by forming supportive rings at their attachment points. 3. It provides electrical insulation between the atria and ventricles. This insulation ensures that muscle impulses are not spread randomly throughout the heart and thus prevents the heart chambers from beating at the same time. 4. It provides a rigid framework for which the attachment of cardiac muscle tissues rely on. We will also discuss words such as systole, which reflects the period of contraction and emptying, diastole, which reflects the period of relaxation and filling, and you will need to understand these words with respect to the chambers, because you will learn during the cardiac cycle of our lecture that the atrial and ventricular events are not the same, and you will have to graphically show this as well. You'll also learn about something called Ohm's law, which basically states that change in pressure is equal to flow times resistance. We will go over this many times. The pressures generated by the right and left sides of the heart are also different. You'll learn more about this in lecture. And lastly, we will pay some time in lecture to discuss what happens to valves, how they can be damaged, and how can the valves be less flexible or more rigid. I'd like to review the fetal blood circulation that you learned in anatomy. Here is a picture showing you the pathway of fetal blood through fetal vessels. Let's begin with some general observations. First, a fetus is not breathing oxygen, and the lungs are collapsed as they are not fully developed nor mature enough to create an important molecule called surfactant that helps to inflate them. As such, the baby depends on the placenta, an organ attached to mom's uterus, for oxygen and carbon dioxide exchange. A picture of the placenta is shown at the bottom left. Now, let's start with the placenta for our fetal circulation story. Mom's and baby's red blood cells have just passed each other, in separate vessels of course, in the placenta in a counter-current fashion. The oxygen from mom's adult hemoglobin has just diffused off and entered baby's blood and bound to baby's fetal hemoglobin molecule. Remember, it does have greater affinity for oxygen. Now the blood re-enters the baby through the umbilical vein. It is a vein because it is leading back to the baby's heart, even though it carries the most oxygen-rich blood in the fetal circulation. The next stop for any blood coming from the abdominal cavity should be the liver for detoxification of the blood. However, baby has not eaten anything and gets its primary nutrients from mom's blood. So there is no reason to go to the liver, which is good because the hepatocytes are too immature to filter the blood properly at this point in the baby's life anyway. So the blood is shunted away to bypass the liver through a structure called the ductus venosus. Now the blood enters the inferior vena cava. Notice that this vein is colored red in this picture. It is because it is carrying oxygen-rich blood still. Now the oxygen-rich blood from the inferior vena cava mixes with the superior vena cava in the right atrium. Most of this blood goes through a hole in the atrial septum called the foramen ovale. Why would there be a hole in the baby's heart? Well, again, the baby's lungs are collapsed as the baby is not breathing air. So there is no need to pump blood to the pulmonary circuit. Additionally, because the lungs are collapsed, this increases the pulmonary pressures and prevents blood from flowing into the pulmonary capillary beds. As such, the foramen ovale lets most of the blood from the right atrium to directly enter the left atrium, where it proceeds to the left ventricle and out to the aorta. What happens to the little amount of blood that enters the right ventricle? Well, it does get to the pulmonary trunk. However, we have another special fetal structure at the end of the pulmonary trunk, where it bifurcates into the right and left pulmonary arteries. This special structure is called the ductus arteriosus. Because the pressures in the pulmonary circuit are so great, the blood is shunted through the ductus arteriosus into the aortic arch. This special artery creates a right to left shunt. By that I mean, the blood is shunted from the right side of the heart to the systemic circuit on the left to avoid the pulmonary circuit. Now the blood enters the systemic circuit and delivers oxygen-rich and nutrient-rich blood to the tissues of the fetus. Blood that needs to be reloaded with oxygen and nutrients flows out of the baby through two umbilical arteries that are branches of the internal iliac artery and carries blood out to the placenta. This is a flow chart to summarize all the events I just described in the previous slide. Blood entering the right atrium should flow into the right ventricle, and this blood is slotted to enter the pulmonary circuit. However, the lungs are collapsed in the fetus, and this created intense pulmonary pressures. These high pressures will prohibit blood from entering the pulmonary capillary beds. As such, the blood needs to be shunted to the left side of the heart. There are two pathways to shunt the blood. Most of the blood goes directly from the right atrium to the left atrium through the foramen ovale. What little blood that enters the right ventricle and exits through the pulmonary trunk is going to go from the pulmonary trunk to the aorta through a special vessel called the ductus arteriosus. Ultimately, the blood flows from the right side of the heart to the left to enter the systemic circuit. The basic changes in the fetal circulation at birth are discussed in Chapter 23 in relation to congenital anomalies of the ductus arteriosus and foramen ovale that persist throughout life in a few persons. What I'm about to describe is from Guyton and Hall's chapter on fetal and neonatal physiology. The primary changes in the circulation at birth are, first, loss of the tremendous blood flow through the placenta, which approximately doubles the systemic vascular resistance at birth, which will lead to increases in aortic pressure as well as increases in pressures in the left ventricle and left atrium. Second, the pulmonary vascular resistance greatly decreases as a result of expansion of the lungs. In the unexpanded fetal lungs, the blood vessels have been compressed because of the small volume of the lungs. Immediately upon expansion, these vessels are no longer compressed, and the resistance to blood flow decreases several-fold. All these changes together reduce the resistance to blood flow through the lungs as much as 5-fold, which reduces the pulmonary arterial pressure, right ventricular pressure, and right atrial pressure. The low right atrial pressure and the high left atrial pressure cause blood now to attempt to flow backward through the foramen ovale, that is, from the left atrium into the right atrium, rather than in the other direction as occurred during fetal life. Consequently, the small valve that lies over the foramen ovale on the left side of the atrial septum closes over this opening, thereby preventing further flow through the foramen ovale. In 2/3 of all people, the valve becomes adherent over the foramen ovale within a few months to a few years and forms a permanent closure. But even if permanent closure does not occur, the left atrial pressure throughout life normally remains 2 to 4 millimeters of mercury greater than the right atrial pressure, and the back pressure keeps the valve closed. The ductus arteriosus also closes, but for different reasons. First, the increased systemic resistance elevates the aortic pressure, while the decreased pulmonary resistance reduces the pulmonary arterial pressure. As a consequence, after birth, blood begins to flow backward from the aorta into the pulmonary artery through the ductus arteriosus, rather than in the other direction as in fetal life. However, after only a few hours, the muscle wall of the ductus arteriosus constricts markedly, and within 1 to 8 days, the constriction is usually sufficient to stop all blood flow. The cause of ductus arteriosus closure relates to the increased oxygenation of blood flowing through the ductus. In fetal life, the partial pressure of oxygen at the ductus is only 15 to 20 millimeters of mercury, but it increases to about 100 millimeters of mercury in a few hours after birth. Furthermore, many experiments have shown that the degree of contraction of the smooth muscle in the ductus wall is highly related to this availability of oxygen. In one of several thousand infants, the ductus fails to close, resulting in patent ductus arteriosus, or PDA, the consequences of which will be discussed later, and you can also find them discussed in Chapter 23. The failure of closure has been postulated as a result from excessive ductus dilation caused by vasodilating prostaglandins in the ductus wall. In fact, at birth, these vasodilating prostaglandin levels are supposed to drop. Lastly, I'd like to address how the ductus venosus closes. Remember, the blood is traveling through this particular vessel to bypass the liver. Immediately after birth, blood flow through the umbilical vein ceases, but most of the portal blood still flows through the ductus venosus, with only a small amount passing through the channels of the liver. However, within 1 to 3 hours, the muscle wall of the ductus venosus contracts strongly and closes this avenue of flow. As a consequence, the portal venous pressure rises, and this increase in pressure is enough to force portal venous blood flow through the liver sinuses. Let's review some of these events again. The foramen ovale is a hole in the interatrial septum, and it is a right to left shunt. Most of the blood is traveling through the shunt. How does it close? After birth, the umbilical veins and arteries are clamped and cut. This will ultimately lead to an increase in systemic pressure. Additionally, the baby's lungs are now inflated, and baby is breathing on his or her own. This means the pulmonary pressures are now very low. We have lower pressures in the right side of the heart than on the left side of the heart, and therefore this now closes the flap that is found in the left atria of the foramen ovale against the interatrial septum, and with time this flap should seal. And this now generates the fossa ovalis. The ductus arteriosus is again another right to left shunt, and it connects the pulmonary trunk to the aorta. When the baby starts to breathe on its own, the levels of oxygen within its blood plasma and red blood cells will begin to rise. This increase in oxygen partial pressure is the primary signal to cause the ductus arteriosus muscular wall to vasoconstrict, and with time, no blood flow should be traveling through the ductus arteriosus, and fibrous material should start to be deposited. the ductus arteriosus will turn into the ligamentum arteriosum. During fetal development, the ductus arteriosus is a right to left shunt because the lungs are collapsed during fetal life and blood flow bypasses the lungs and enters the aorta through the ductus arteriosus, which connects the pulmonary artery and aorta. After birth, the high oxygen concentration in the aortic blood that passes through the ductus arteriosus causes closure of the ductus arteriosus in most newborns. Occasionally, the ductus arteriosus does not close, and the condition is called patent or, quote, opened ductus arteriosus. With patent ductus arteriosus, the high pressure in the aorta forces blood through the open ductus arteriosus and into the pulmonary artery, and this is why we call it a left to right shunt. As such, the blood recirculates several times through the lungs. The following are features of patent ductus arteriosus. 1. Blood volume will increase to compensate for the decrease in the baby's cardiac output. You should review the roles the kidneys have in releasing erythropoietin and why they release it. 2. There is a murmur or heart sound heard throughout systole and diastole. More lecture will be spent on murmurs. 3. There is left ventricular hypertrophy, and this occurs because of the extra blood the left ventricle must pump. 4. There is right ventricular hypertrophy, because of high pulmonary pressure and resulting to the backflow of blood from the aorta to the pulmonary trunk. 5. There is pulmonary edema that can occur if the left heart is too overloaded. Tetralogy of Fallot is a right to left shunt. With tetralogy of Fallot, there are 4 abnormalities of the heart. The aorta is, the aorta is displaced over the ventricular septum and originates from the right ventricle. Secondly, a ventricular septal defect is also present, causing the right ventricle to pump both left and right ventricular blood through the aorta. 3. The pulmonary artery is narrow, and this is called pulmonary valve stenosis. And because of the high pulmonary arterial resistance, much of the right ventricular blood is shunted into the aorta. 4. Right ventricular hypertrophy occurs because the right side of the heart must pump large quantities of blood against the high pressure in the aorta. Surgical treatment of this condition is not only helpful, but oftentimes necessary. The baby is overall cyanotic because much of the blood fails to enter the pulmonary circuit for proper gas exchange. Therefore, babies with tetralogy of Fallot are called, quote, blue babies. This concludes our review of the heart, fetal circulation, and changes at birth.